Students, this is Dr. Lisa Pullen. I'm going to be lecturing on anxiety and obsessive compulsive related disorders. If you have any questions about this lecture or any questions about Nursing 542, please feel free to reach out to me or Dr. Livingston. As with bipolar and related disorders that I lectured on last week, I've worked extensively with patients who have mood and anxiety disorders. Those are probably the two most common diagnoses that I have worked with. Anxiety is a universal emotion. What do I mean by that? It doesn't matter where in the country, where in the world you live. A lot of people will experience an anxiety feeling, anxious feeling, at least once in their lifetime. A lot of people more than that. And it's when it becomes unbearable that often people seek help. Otherwise, a lot of times people wait for years before they will seek help for anxiety because they look normal and they feel embarrassed. I often get, "Do you think I'm crazy?" when a patient comes to me for an initial evaluation. No, I don't. You have anxiety and you've let it go for so long that it's at the level that, we need to consider either therapy or med management or both. So, the ones that are bolded, students, we're going to talk about in this lecture, which is separation anxiety disorder. We also have selective mutism. We also have specific phobia. Those will be covered next semester. We'll talk about social anxiety today, panic disorder, agoraphobia, and generalized anxiety disorder. And again, in my career, I have treated all of these disorders. The med treatment is very similar for all of these disorders. And of course, we will focus more on that as you progress, through the semester and next semester. Body dysphoric disorder, students, and hoarding disorder will be covered in future courses. So we'll talk about obsessive compulsive disorder, or OCD, trichotillomania, students, that's the pulling of hair, excoriation disorder. There are several clinical rating scales for anxiety disorders. Students, I mentioned rating scales, questionnaires with the bipolar and related disorder lecture. There's a lot of great scales, in your textbooks, in your Kaplan, in your Wheeler, that you can look at. I have used the social avoidance and distress scale, and I've also used the Lebowitz social anxiety scale. I think it does help. And some patients, have read a lot now that we have access to the internet about, disorders and about, certain questionnaires and even rating scales that they will often tell me about. But those patients, sometimes they want, an objective measure, like a score, like I mentioned, students, on the bipolar and related disorder lecture. So, there's 4 that are mentioned on this PowerPoint. The fear questionnaire, it is a 24-item instrument developed to assess outcome of work with patients with phobic disorders, agoraphobia, blood injury phobia, and social phobia. Then, like I've said, I've used the social avoidance and distress scale, the SAD. It's a 20-item scale developed to measure stress in social situations and avoidance of social situations that cause stress. And then we have the social anxiety thoughts questionnaire, the SAT. It is a 21-item scale designed to measure frequency of thoughts associated with social distress or anxiety. And then the Lebowitz social anxiety scale, it's a 24-item scale. It measures severity of social anxiety, and it can be used to measure response to treatment. Then there are a couple more I have used the Hamilton Anxiety Rating Scale. It is often used by clinicians, like it says it's administered by clinicians, excuse me. It's only a 14-item scale, so it can be administered really quickly. It's used for the assessment of severity of overall anxiety in patients with diagnosed anxiety or depressive disorders and monitoring outcomes of treatment. Then you have your panic disorders severity scale. Then you have your panic attack symptoms questionnaire. It's a 33-item instrument designed to measure duration, severity of symptoms during panic attacks, and it's able to differentiate between patients experiencing panic attacks and those with anxiety disorders not experiencing panic attacks. I have had colleagues, and I have used this scale a couple of times with patients I have treated for panic attacks. The International Trauma Questionnaire and the Complex Trauma Questionnaire. So, we'll talk about fear and anxiety and the human responses to threats to survival. The amygdala, students, is the primary brain structure involved in fear and anxiety responses. Fear, we know the response to a known, definite, or definitive and external threat. We know what the threat is. And that's a big difference between fear and anxiety. Fear is hardwired in the brain. It protects humans from potential harm. Norepinephrine is the primary neurotransmitter system involved in fear. And anxiety is a response to threat that is unknown, vague, internal or indirect threat. Loss of people or things that represent security. You think about someone that's had a job, especially one that's had a job for a long time, and they lose their job. They lose their home. They lose their financial support, their role in life or relationships. So students, that is associated with, anxiety. And the gamma aminobutyric acid, or GABA, benzodiazepine system, is the primary neurotransmitter system involved in anxiety. So what is the clinical presentation? When we look at panic attacks, it's often present with medical symptoms or medical emergency with no identified physical or medical cause. But students, remember what I said, a lot of people will wait years to seek mental health treatment for anxiety disorders. And this is an example with panic attacks. People will go and seek medical care trying to rule out, is it a heart attack? They don't perceive it as something that is caused by their emotions, their emotional state. So people can present with similar symptoms too, as the slide shows you: cardiovascular symptoms, palpitations, chest pain, and paresthesia, numbing, tingling, or pins and needles feeling. So again, people think they're having a heart attack, but you have to, in therapy, guide the patient through relaxation, CBT, mindfulness, and have them tell themselves, this is not a heart attack when they're feeling these symptoms. This is just a panic attack. And it's self-talk. This will go away in just a few minutes. I am going to be okay. I'm not going to die from this. And this is where you're working on the cognitive symptoms such as depersonalization or fear of losing their mind. And it often starts 8 to 10 years before for psychiatric treatment. Again, students, that is just reiterating what I have said, that patients wait a long time to seek psychiatric treatment, especially more so for anxiety disorders. 70% have contacted at least 10 physicians, neurologists, cardiologists, and gastroenterologists without a correct diagnosis being made. So imagine what that costs the healthcare system, what that costs the patient. And again, they can spend thousands of dollars because they think it's something physiological going on with them. Avoidance behaviors may remain after anxiety symptoms are reduced. They may avoid shopping alone, elevators, or malls. Had a patient one time that had a fear of elevators. What I worked with her on is just showing pictures and us talking about her fear. What was it about the elevator that she had a fear about? Well, when she was a child with her parents, they got stuck on an elevator. And this can take years of therapy, students. I worked with this patient 3+ years. And we finally went to the mall and we went down the elevator. And she actually handled it very, very well. She is no longer my patient, but I've heard from a family member that yes, today she still takes elevators on occasion, especially when that might be the only option. Let me point out that the functional impairment includes avoidance behaviors that lead to restrictive lives for the patient and often their family. Students, people can become reclusive people with anxiety disorders. I saw a program one time where a lady stayed indoors for 20 years. She would not even go out to her mailbox because of her anxiety and her panic attacks. She waited 20 years to seek treatment. It's very treatable, and patients can live productive lives. But again, they're hesitant because they look normal. They think, they're going to be perceived as being crazy. But explain to them about gamma aminobutyric, GABA. Explain to them that although it feels like they're having a heart attack, that in fact it's a panic attack, and work with them about their feelings in regards to that. Usually occur once or twice a week. I do want to say that an initial attack may be preceded by a triggering life event that is often a disruption of a relationship or an attachment bond that disturbs the individual's sense of safety and security in the world. That's very common. It's usually away from home and it resolves without treatment. It can leave the patient feeling exhausted and drained for up to 2 days. The initial attack may be preceded by a triggering life event that I've said that disturbs the individual's sense of safety and security in the world. And that may be the reason that they become reclusive. There's a high risk for depression. Hope that you can see that, especially if they have the fear of leaving their home and substance abuse because they don't seek treatment. So they medicate with other substances. They have impaired marital, parental, work and social functioning, and suicide. Then there's anticipatory anxiety related to panic attacks and avoidance behaviors. There's a great impairment of social, vocational, and role functioning and lower quality of life than the general population. I had a graduate student when I was at the Clemson University. She had a fear of going over bridges. Initially, she stopped her car before, going over the bridge, opened her hood, checking her motor, checking her tires. That would, satisfy her initially doing that one time. But because she did not seek treatment, it got to where she was spending an hour and a half and 2 hours checking, rechecking before she could go over a bridge. But once she sought treatment and got into therapy and got on an SSRI, that's the common medication we use to treat anxiety disorders, she was fine, going over a bridge. Okay, there's also the assessment of panic attacks. Again, we're focused on an assessment. So the length is typically lasts 5 to 20 minutes with peak intensity of anxiety occurring about 10 minutes after first symptoms with waves of panic attacks perceived as continuous. And again, this varies per person. They may feel agitated after the panic attack, interrupted as continuation of the panic attack. They may have severe anticipatory anxiety that may be interpreted as a panic attack. Triggers, students, it's like with post-traumatic stress disorder. There's certain triggers that can trigger nightmares and flashbacks, but certain events, smell, place, memory, or even situation or person. And the timing and setting, nocturnal, panic attack, social setting, upon waking, when alone, those can be particular settings or specific timing that can cause panic attack. Stages of panic attacks. Again, students, depression, like I said, may occur. Higher risk for alcohol or substance abuse, impaired marital, parenting, work, and social functioning, and suicide can occur. Stages of panic attacks. Number 1 is the subpanic, where you have tachycardia, lightheadedness, and shortness of breath. 50% of patients start this way. You can see when they feel like they're having a heart attack. 2, start with fear of loss of control, freezing, or flight. 3, fear that panic symptoms are related to physical illness. 4, anticipatory anxiety, worry about future panic attacks. 5, agoraphobia. They avoid any place or situation in which escape might be difficult or impossible, or in which a panic attack would be embarrassing. Eventually, like I've said, they don't leave their home at all. Then we have agoraphobia. In severe forms, individuals can become completely homebound and dependent on others. They experience demoralization, depression, and substance abuse are common. 30 to 50% experience panic attacks or panic disorder prior to onset of agoraphobia. Onset typically prior to age 35 is 66%. That's significant, with mean onset of age 17. Substantial risks late adolescence and early adulthood. Again, a lot of life changes at that age. Course is typically chronic and persistent, only 10% complete remission. Then, students, we have social anxiety disorder. Situations of social fear of embarrassment may include meeting new people, attending parties, meetings or interviews, speaking in front of people, eating in front of people, using public bathrooms, and dealing with authority figures. Again, over the years, working with patients who have SAD, a lot of it, they talk about stage fright, eating in front of people. So it's characterized by a fear of social or performance situations in which the individual may experience embarrassment. They often have poor social skills, such as making eye contact, initiating conversations, responding to others, engaging in use of safety behaviors, limited social fear, it's discrete or fear of many social situations. It's generalized. Symptoms of anxiety, palpitations, racing heart rate, tremors, sweating, shaking of their hands, diarrhea, blushing is very common, students, with SAD. Confusion, dry mouth, nausea, or even tearfulness. Symptoms may be viewed as a response to a threat to social status or reputation. Patients are afraid that often others will think that they are weak. I've used the term crazy. I hear that a lot with patients seeking help for anxiety, or stupid. Anticipating and worrying about an event or situation far in advance that may not, in fact, ever happen. Hypersensitivity to criticism, negative evaluation or rejection, and problems with assertiveness and self-esteem. Social phobia, Blushing, as I've said, students, is common. It's the key physical symptom of social phobia or social anxiety disorder. You will see those two terms used interchangeably. During anticipation of public speaking, patients with discrete social anxiety disorder have elevated heart rate similar to panic disorder. So, let's look at social anxiety disorder in academic settings. Test anxiety can cause SAD, difficulties in participating in class, especially when you're standing up in front of your colleagues or dropping out of school. At work, it can affect your achievement. You can underachieve due to problems with public speaking and being assertive. So a lot of times maybe a person should not consider a job that involves public speaking, being in the limelight or being around a lot of people. Cognitive distortions are often present, they have a negative self-evaluation of social performances, discounting social competence and positive interaction, negative perceptions of physical, mental health, and satisfaction with life. In severe forms, we see unemployment due to inability to participate in job interviews, social networks that are limited to family. Yes, it's very common. Diminished quality of life. Yes, an increased risk of suicide. Hopefully you can see, again, when people go years without treatment, these symptoms that occur with severe forms of SAD. Sad. Social anxiety disorder in child and adolescent. Assessment. Again, students, exposure to the feared situations produces anxiety that adults may recognize as unreasonable, but children may not. Children may often experience fear of situations that adults find unreasonable. So, SAD with child and adolescent, what are you going to see on assessment findings? Failing grades, dropping out of school, not graduating from high school, increased risk for alcohol abuse, parental behaviors such as modeling social avoidance and fear of social evaluation, parents who are distant and rejecting. Students, go back to that first semester when we talked about the different theories. We talked about Bowlby's, attachment theory. When parents do not bond, especially the mother, the child feels, neglected. Parents are distant and rejecting. When there's maternal depression, nervousness over caring for a child, irritability, and shyness, that can certainly impact the child and adolescent's development. They develop insecure attachment patterns. Again, we talked about that the very first semester. Observing humiliating social experiences or experiencing peer rejection. Then we have social anxiety disorder versus shyness. Is the person just shy? Shared symptoms, somatic arousal, which may be increased heart rate, maybe some GI upset, and fear of negative evaluation. Difference in prevalence. SAD ranges from 3 to 13% of the general population, whereas shyness is reported in 40 to 50% of college students. Differences are in the degree of severity of avoidance, impairment, and course. Agree. Among extremely shy individuals, many meet the criteria for generalized SAD and avoidant personality disorder. Yes, they do. So, what are the associated features? Individuals may have a limited social fear or fear of many social situations. Children may often experience fear of situations that adults find unreasonable. Somatic symptoms are present: sweating, blushing, dry mouth, racing heart rate, nausea, or even tearfulness. Cognitive distortions are often present. negative self-evaluation of social performances, discounting social competence, and positive interaction. Okay, let's talk about generalized anxiety disorder, or GAD. People with GAD, students, they're excessive worriers. They worry that it's a worry that is difficult for them to control. It causes serious distress and interferes with the person's daily living. GAD can cause substantial impairment in quality of life, global role functioning, subjective well-being, and perceived health. It's not uncommon for these people, again, to feel like something physiological is going on rather than their emotional state. They will seek and do a lot of doctor shopping, have a list of numerous doctors. It's not uncommon for them to have a long list of medications that have been prescribed, because unfortunately, when primary care may attempt to explain that this is, due to emotions, the patient may not be open to hearing that because they feel like it's something physiological. Or sometimes, it happens. People working in primary care, because these patients can be demanding at times. They may, well, I'll just write this script and get the patient out the door before they ever seek, and come to the realization that it is their emotional well-being that is causing them to have this generalized anxiety. Primary feature, students, is excessive anxiety, worry. They worry about things before they ever do occur or may not. The likelihood of it ever occurring is very slim to none. Everyday things such as work, finances, health, repairs, and tardiness, social acceptance, and marital adjustment. You've probably known someone in your lifetime that may be a chronic worrier. Degree of worrying is out of proportion, students, to the likelihood that something adverse will happen and to the impact if something does occur. Majority report being anxious at least 50% of each day. It is a belief that they have little control over their emotions and worrying. They're ashamed of failure to control their symptoms. They may believe that by worrying, they may prevent a negative event from occurring. Like I said, some distorted cognitions. That's why CBT is a good therapy for these patients to be involved with. Hypervigilance is common, and multiple somatic symptoms are common. So what have I said about somatic symptoms? What would you anticipate that the patient seeking care with you would report in regards to their somatic symptoms? Typically GI, neurological, headaches, diarrhea, constipation, IBS. Those are just a few. So, early life history. They're typically people who have had, anxiety in their life. They have socially isolated. They've had academic difficulties. They have obsessions, and they have disturbed family situations. A lot of times, parents, may have a diagnosis of GAD. They're moderately anxious as children. GAD with exposure to stressors. Symptoms may fluctuate but often persist throughout life. Less than 1/3 experience spontaneous remission. About 80% have lifelong symptoms. Onset typically after age 20 years. Late onset is after age 50, after an episode of depression or other negative event in their life that occurs in the year before. Early onset associated with more psychiatric comorbidities and greater severity. Yes, Late onset is associated with more functional impairment. Associated symptoms of GAD. Students, look at the biological. There are 8 listed there. And I think I've seen those throughout the year. I mentioned irritable bowel syndrome, GI upset, diarrhea, several more that are listed there. Psychological. You see those 6 psychological associated symptoms of GAD. And then you have the 3 social associated symptoms of GAD. They are high-level, quote-unquote, worriers. Individuals who experience a high level of worrying but do not meet the criteria for GAD. Less impaired by worrying than patients with GAD. Patients with GAD experience less control over negative intrusive thoughts and experience higher levels of somatic hyperarousal. Yes, there can be people that are worriers that do not meet the criteria if you look at your DSM-5 for GAD. So you need to familiarize yourself with that criteria. Then we have obsessive compulsive disorder, or OCD. It's characterized by thoughts, images, or impulses that are experienced as anxiety-producing intrusive obsessions. It includes repetitive behaviors or mental acts that the individual feels compelled to do to reduce the anxiety in the obsessions. Themes of most obsessions and compulsions relate to issues of security, safety, and survival. They do things, students, like checking to make sure the stove is turned off, checking to make sure the doors are locked, washing their hands. I had a patient, she would wash her hands with Clorox to the point that they were raw, bleeding. Hoarding. Several patients' stories about patients hoarding. Need for symmetry. Maybe their closet, they have all blues, all reds, all greens, all yellows, all pinks. I do that, but I do not have OCD. And that's not uncommon, and to arrange things, your socks in a drawer, Counting, passage of time, moons or seasons. Counting the tiles on the walls, counting the tiles on the floors, not stepping on the cracks. A good movie to watch is As Good as It Gets. Jack Nicholson won an Academy Award. He had issues with OCD. They're into cleanliness. There can be germophobia, phobias to germs. And if you watch that movie, you will see where he took his on plastic silverware when he went out to eat. But he didn't go out a lot because, again, he had anxiety and he was a bit reclusive. Monitoring the environment. Yes, they monitor the environment. Is it clean? OCD, age of onset. Symptoms begin in adolescence or early adulthood, maybe as young as 2 to 4 years of age. Late onset, 26 to 35 years, is more likely to occur in women. Approximately 1/3 of first episodes begin 10 to 15 years of age. About half of adults with OCD report having symptoms during childhood or adolescence. Again, students, patients with OCD use safety-seeking behaviors. They have behavioral rituals, neutralizing acts, avoidance and suppression of negative thoughts. They reduce, students, they reduce the patient's distress, these things that they do for a short time, but in the long run, they maintain or strengthen the obsessions and the urge to perform rituals or neutralizing behaviors. Patients often keep their distress secret for fear that others will think they are crazy. Like I have already said, patients with OCD are resistant to change because change, both positive and negative, brings stress. They need to be certain of things, students. They need to be in control in order to cope with their environment, to keep it safe. They have a need for perfection because of their fears of the consequences of not achieving perfection. Again, I would encourage you to watch the movie As Good as It Gets. So, what are some of the patterns of dysfunctional beliefs? The sense of responsibility for things happening. They feel that. Overestimation of threats, perfectionism, intolerance of uncertainty, importance of controlling their thoughts. Remember negative things more than positive things with more difficulty ignoring intrusive thoughts. They equate thoughts with actions. Believe that negative thoughts and doubts are the same as the behavior and that the thoughts make the event more likely to happen. They believe that certain thoughts may be harmful and they must stop them in order to prevent the harmful event from occurring. They use safety-seeking behaviors, such as behavioral rituals, like I said, neutralizing acts, avoidance, and suppression of negative thoughts. Students, this concludes the presentation for anxiety and obsessive compulsive disorder. If you have any questions, again, please feel free to reach out to me or Dr. Livingston at any time. Thank you.